Well, good afternoon and welcome. My name is Sunil Kumar. I am the provost of the university, and President Daniel sends his regrets he couldn't be here today. And so you'll have to make do with a somewhat inferior alternative. And I'm here to introduce the award. The PFA was endowed by two of our alums, Lou Foster and Kathy Pike, and is the, I would say, most prestigious internal award for research that we give out. And it's intended to give it to someone who's at the cusp of doing something big, because as Deidra will soon find out, this isn't intended to be an award for past accomplishment as much as a bribe, an incentive, a threat, whatever you might want to think of, for future achievement. And that's really what this is intended to do. And past winners and past lectures have been very interesting. I'm hoping your lecture will be somewhat different from last year's, which was Michael Hirsch in Peabody. He was a composer. And Michael decided to do a 90-minute piece on the theme of death. And so we watched birds die in slow motion on a video while some really horrible music played at 3 o'clock in the afternoon. Michael did win a Pulitzer for that, so I guess we, so I'm hoping that Deidra's talk will be, and given the topic of kidney health equity, will be definitely more uplifting than that, and perhaps illuminating as well. So I couldn't be happier that Deidra Crews is the winner of what is the university's most prestigious early mid-career award that we have. And with that, I'll turn it over to Paul Rothman to introduce our winner. So thank you again for coming.
Thank you, Sunil. Good afternoon. So it's a real pleasure today to help celebrate Deidra Crews and recognize her awarding of this President's Frontier Award and hear a little bit about her work. So for those of you who don't know, when this award is given, President Daniels likes to surprise the recipient. And so every year he figures out some way to present the award with a group of leaders from the institution in a way that the recipient won't know. So I think he got Lisa Cooper to help out. And I think Lisa either scheduled a fake meeting but in a very serious way, and got Deidra in the room, and in the room we were, and that's when Ron gave Deidra the award. And I was looking at the smile. So, there are smiles. There's this smile, and Deidra's got a wonderful smile that she uses in her pictures all the time. And I think that's a pretty good smile, right? But then there's a smile you get when you get $250,000 for your research. And it's a little bit different. And I remember, Deidra, watching you and the joy that you had, which was really wonderful. And I will say it's, I think, a well-deserved honor for you to have received this award. So they asked me to read all her titles. So Deidra is Associate Professor and Associate Vice Chair for Diversity and Inclusion in the Department of Medicine. She holds faculty appointments with the School of Nursing, the Welsh Center for Prevention, Epidemiology, Clinical Research, the Center of Aging and Health, and the Center for Health Equity. Did I miss any of them? No, I don't think. And she's a nephrologist on top of it. And so, you think about Deidra, and I will say it's people like Deidra that make me truly proud to be here at Hopkins, because she does rigorous research around things that are not always rigorously studied. And in this case, as we'll hear about, she has really been focused on kidney disease, hypertension, and healthcare disparities, and trying to understand the linkage. I think most people in this room, I won't have to talk to the converted, but most people know that there is disparities in the incidence of chronic renal failure and dialysis among underrepresented minorities, specifically African Americans in this country. And did just try to work on that and try to understand not only the disparities, and so you can find them, I think, pretty readily, but can we do anything to intervene to change it? And that's why I love our healthcare disparities group, and I look at Lisa, too, as people who not only recognize the issue, but try to have real-world solutions to these very difficult issues. And so Deidra's last study, which I assume she's going to talk a little bit about, is how you might provide healthy food to people with hypertension and some early renal failure to see if you can change the course of their disease. It is really what we should be doing here at Hopkins, and we're so proud to have Deidra leading this study. So with that, I'd like to introduce today's lecturer, Dr. Deidra Crews.
Thank you, Dr. Rothman, for that very kind introduction, and thanks to all of you for being here today. Turn to my cover slide here. I am just thrilled and tremendously honored to stand before you all, to stand before so many of you today as this year's recipient of the President's Frontier Award. And while certainly it will provide a boost to the work that myself and my colleagues are doing together and the work that we hope to continue to do, I'm very grateful for the platform that this award has given to kidney disease and kidney health equity. And I think it's really going to help us to move the field forward. So as I mentioned, I'm really grateful for this platform that this award has provided. And I'm particularly grateful to Mr. Forrester and Dr. Pike for their generosity and their commitment to supporting faculty here at Johns Hopkins. I actually had the opportunity to meet Dr. Pike, and we met for coffee just a short while after I received the President's Frontier Award. And as I approached the restaurant where I was going to meet her, I remember thinking to myself, how do you greet a person who's giving you $250,000? And then I thought, a hug will have to be in order. And so I was really pleased that she was receptive to the hug that I definitely wanted to give her. And so as I would also like to wholeheartedly thank Dr. Lisa Cooper, who's the director of the Johns Hopkins Center for Health Equity, not only for nominating me for this award, but also for the pioneering work that she began at a time when I'm not sure that a crowd like this would have come out for a health equity talk, and there was a lot of skepticism around the validity of a focus on health equity research. And she's been such an exemplar of not only what to do in this line of work, but how to do it in such a way that it can have real impact in people's lives. And I can't thank her enough for that. And so during our time together today, I want to share a bit about my personal journey and also the work that my colleagues and I are doing and the work that we plan to do addressing kidney disease and kidney health equity. And I'll highlight some of the work that's part of my plans for the President's Frontier Award using this green star. And I'll share some thoughts on how kidney disease and kidney health equity and actually overall health equity might one day be achieved. And I hope that by the end of our time together that we'll have convinced you all that there's a role for each of us to play in achieving health equity. And so my journey began in a town called Danville, Virginia, which is a manufacturing town of around 40,000 people that's located on the Carolina border. And this was actually, just for those who are history buffs, this was actually the last capital of the Confederacy. And I'm fortunate to have a loving and supportive family, including my wonderful husband, Daryl, who's here today, and our daughter, Charlotte, who is fired up about turning 8 this week. My mother and father, who are on the far right there in that photo, my mother is a retired elementary school principal, and my father worked for nearly 40 years as a pipe fitter with Goodyear Tire and Rubber. And he's also a deacon of a Southern Baptist church. And so now you pretty much know everything you need to know about the rules and regulations under which my brother and I lived as we were being raised by our parents. I come from a very large family, especially on my father's side. Actually, some of my cousins are here from my father's side. And when I say large, I mean that we recently tabulated that my father has 90 first and second cousins. As the eldest grandchild on my father's side, so actually I'm the eldest on both sides, but this is a photo with my grandmother Margaret. You'd think that as the eldest I might be her favorite, but as it turns out I have pretty stiff competition from my brother and the other cousins that are in this photo. And so it's actually been a remarkable year for our family. I was honored with this award, and then a few months after my receiving this award, 2 of my cousins became the first pair of brothers to be drafted in the first round of the National Football League. Yeah, and as if that wasn't enough, just a few weeks ago, another group of our cousins posted an incredible performance on Family Feud. And so we've had quite a year. And so I have so very many people to thank for their support in my career development, but there are a few pivotal people and experiences that I'd like to highlight. My earliest memory that I have in terms of, if someone asked me what I wanted to be when I grew up, was that I would reply, a scientist. And it would be many years later, a few years after that, I would say that I started to want to become a physician. And it would be many years, though, after that before I learned that I could actually be both, that I could be a physician scientist. And I have to thank Dr. Jack Turner, who is a pathologist in Danville, Virginia, where I'm from, who established this Medical Explorers Club that was for kind of the middle school age children in our community, that allowed us to come in and get some exposure to pathology. So because he was the first physician that I had actually ever known who wasn't my own personal physician, for the longest time I wanted to be a pathologist, and my renal pathology colleagues love it when I tell the story. But it's, so I went on and kind of continued in this path and focused on science. And my academic journey, and certainly my subsequent interest in social determinants of health, was also very strongly influenced by my aunt, my mother's sister, Dr. Charlotte Fitzgerald. And she was a sociology professor at what was then Randolph-Macon College. It's now a university. And we lost her far too early to complications of type 1 diabetes and end-stage kidney disease. But her determination and her focus on continuing to work and also to be a peer mentor to others who are battling end-stage kidney disease continues to inspire me to this day. As a fourth-year medical student at St. Louis University, I had the wonderful opportunity to do a month-long research rotation with Dr. David Levine and Miss Lee Bone here at Hopkins. This was as a visiting student. And this was on a study called Project Sugar 2. And it was an intervention study that was addressing diabetes control among African Americans here in Baltimore. And it included a nurse case manager and community health workers. And this was my first introduction to community-engaged research, and it was also my first introduction to Hopkins. And they both have continued to be incredibly supportive of my career, almost serving as like godparents here in my time at Hopkins. Also, in my fourth year of medical school, I received a travel scholarship to travel to Swaziland, which is in southern Africa. It's now actually called Eswatini. And I traveled there to do a rotation at a local hospital. And it was there that I got my first clear glimpse into what it means to have your health be socially determined. And I'll never forget a young woman that we saw in the clinic there who, at the time when we were there in Swaziland, they were experiencing the third highest rate of HIV in the world. And by that I mean that 1 in 3 people were infected with HIV, and it was included in that number. And when she came to our clinic, she came in with a complaint of a productive cough and also fever and chills. And we ultimately diagnosed her with tuberculosis, which, as many of you know, often can co-occur with HIV. And when we told her that we wanted to admit her to the hospital and treat her for tuberculosis, what she said to us is that she would actually need to travel home first and ask for her husband's permission to be able to be treated, owing to the cost of being treated at the hospital there, where it was sort of, you had to basically pay for every day that you were there, and there was no governmental assistance to help with that. And so she left the clinic and she never returned, and we can only imagine what happened to her. When I graduated from medical school, I was fortunate to match here in the internal medicine residency program, here in the Osler program. And this is where I began to learn how to ask clinically relevant research questions with the help of my earliest research mentors, and those being Drs. Bernard Jarr, who's a nephrologist, and Dr. Neil Poe, who's a general internist. And both of them continued to mentor me. And I'm most grateful that they didn't laugh at or disparage the ideas that I would kind of come to them with. They were pretty lofty ideas. They would always, both of them would actually always use an approach that I'll call gentle redirection. And they would kind of guide me in a way that was going to be more productive. And I'm very grateful to them. And then as I was transitioning into a faculty position, I was also very fortunate to have Drs. Ebony Boulware and Pete Miller, who were my NIH Career Development Award mentors and helped me to see how I could advance some of the observational research that I was doing into developing clinical trials. So today we'll be talking about health equity, and so I thought it would be important to provide at least one definition of health equity. And this is from the Robert Wood Johnson Foundation. And they essentially say that health equity means that everyone has a fair and just opportunity to be healthier. And this requires removing obstacles to health, such as poverty, discrimination, and their consequences. And it includes removing powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. We will be talking about kidney disease, and I'm so excited that all of you signed up to hear a talk about kidney disease. And when we think about chronic kidney disease, it's usually conceptualized as existing across this sort of a continuum where most people have normal kidney function, and then some people will be at increased risk of developing chronic kidney disease, including people who have diabetes or hypertension. And then of those, some will develop kidney damage, which we're usually going to measure through signs of protein in the urine. And of those, some will also go on to develop decreased kidney function, so a decreased ability of the kidneys to clear toxins. And then ultimately, some will develop end-stage kidney disease. This is the portion of the continuum that we usually refer to when we speak of chronic kidney disease. And there are more than 700,000 people in the U.S. who have end-stage kidney disease, but there are many, many more than 30 million in the United States who have earlier forms of kidney disease. And the overwhelming majority of these people will actually never go on to develop end-stage kidney disease, or they will never go on to develop a need for transplantation or dialysis. But instead, they are much more likely to die of cardiovascular disease. And this is why there's, I think in recent years, been a lot more focus around thinking about kidney disease as a marker or a risk factor for cardiovascular disease. Sorry. And so when we think about kidney disease and disparities, the disparities in kidney disease are quite profound. And I'm just sharing with you kind of a few, I think, examples of these disparities. African Americans make up 13% of the U.S. population, but they make up about a third of those who have kidney failure. Hispanic and Native Americans are nearly 2 times as likely as Caucasians to develop kidney failure, and low-income people are twice as likely as high-income individuals to develop kidney failure. And then African Americans, Hispanics, and Asian Americans are less likely to receive living donor kidney transplants than are whites. And I point to this work that was done by my colleague, Dr. Tangela Purnell, because this is the optimal treatment for kidney failure. Transplantation is, and certainly living donor transplantation is the optimal type of kidney to receive. And then awareness of chronic kidney disease is quite low, even among people who have high risk of kidney disease. When we look across kind of all stages of kidney disease, particularly focusing on the earlier stages, only about 10% of people who have that earlier stage of kidney disease actually know about it. And so as you would imagine, then there's much less opportunity to partner with those individuals to try to help them prevent the progression of their disease if they actually aren't even aware that they have it. And so I will spend most of our time today focusing on the United States, but I would be remiss if I didn't note that there are profound disparities that exist in kidney disease across the world. And this is with low and middle income countries being disproportionately affected. And this is the focus of this year's World Kidney Day campaign, which I'm pleased to be a part of. So when we think about kind of, why do we see these disparities in kidney disease? There are a number of different models that have been proposed to help us think about this. This is one by Keith Norris and Alan Nissenson that I like because I find it to be quite comprehensive in that it highlights that there is this interaction between genes and environment that's a key kind of portion of these disparities. We're learning more and more about a particular type of genetic background that is common among African Americans. It's the apolipoprotein L1 gene, and we're learning that does raise the risk of kidney disease among African Americans and people of African ancestry in general. It does not explain all of the risk, and pointing to that there are still other factors, including environmental factors, that are key determinants of these disparities. My colleagues and I, with sort of a focus on understanding that an individual's zip code may actually matter more than their genetic code, and really kind of honing in on those environmental factors, we have worked across a number of different areas that are highlighted here in this diagram, but I wanted to highlight a few of them, those being our work around poverty, discrimination, and then poor nutrition. And I'll just provide a few examples of this work. So in terms of poverty, I've worked for a number of years now with a study called the REGARD study, or the Reasons for Geographic and Racial Differences in Stroke study, which is includes around 30,000 participants who come from what is referred to as the stroke belt and also the stroke buckle. And that happens to be the southern United States and the coastal southern United States. And it's called that area is called that because that's where we see the highest rates of stroke and mortality also from stroke in that region of the country. And so there were a number of kidney markers that were collected through this study. And so we took a look at just the relationship of income level to the finding of protein in the urine, or albuminuria. And we looked also by race, so looking at blacks and whites separately. And essentially what we found was that individuals who had the lowest level of income were more likely to have this protein in the urine, which we know can be a predictor of both cardiovascular disease as well as progressive kidney disease. And we found that this association kind of between, or the linkage between income level and the protein in the urine there was a closer linkage for the black participants in the study. And we went on to kind of account for some other factors that could relate to either income or to protein in the urine, and we continue to have this finding. Which left us wondering about, what is it about being both black and also being poor that might actually increase risk of kidney disease, and that's been something that we've continued to study. So turning to discrimination, I want to highlight some work that I did with Dr. May Badoon, who's here in the audience, and as well as Angie Poggi-Burke. And this was work that we did in the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, which is a Baltimore-based cohort study that is examining disparities both by race as well as by socioeconomic status, and with a particular focus on cardiovascular outcomes, but we've been able to look at a number of kidney outcomes in the study as well. And so here, what I'll share with you is that we were interested in looking at discrimination, and discrimination had been shown in a number of studies really focused on identifying its linkage to hypertension, to cardiovascular disease, and to a number of other conditions. We were excited to be able to provide the first empirical evidence that there was this linkage between discrimination and kidney function. And so what we did was to look at self-reported perceptions of racial and also gender discrimination in 5 different situations. And those included at school, getting a job, at work, at home, or when getting medical care. And we used a well-validated measure called the Experience of Discrimination Scale. What we found, to summarize, is that among white women, we found that high experience of discrimination was associated with having a lower level of baseline kidney function. And we also found that among African American women, both perceived racial discrimination as well as gender discrimination were linked to a lower level of kidney function at follow-up in the study. And so if you're wondering how might stressors like discrimination get under the skin and actually cause conditions like kidney disease and cardiovascular disease, this kind of concept of allostatic load has been studied, and that this is the cumulative impact of physiological wear and tear that's related to maladaptive stress patterns. And these stress patterns can predispose people to disease. And we have been very interested in this, and this is one area that I hope to explore further through this award, working with Dr. Anika Hines, who trained here at Hopkins but is now on faculty at Virginia Commonwealth University, and received a NIH award to try to look at some of these issues. So turning a bit to this idea of poor nutrition and the role that it might play in the disparities we see in kidney disease, many of you, maybe perhaps most of you, are familiar with dietary approaches to stop hypertension diet or eating pattern, or the DASH diet. And it is one that's rich in fruits and vegetables, whole grains, low-fat dairy foods, and includes moderate amounts of meats and very limited amounts of sugars or sweets. And it has been shown to lead to reductions in blood pressure, to prevention of cardiovascular disease, and a number of other favorable health outcomes. And so we were interested in whether there's a relationship between the DASH diet and kidney disease. And this is work that I did with an amazing group of young investigators, Yang Liu, Dr. Casey Rebholz, and Dr. Tanushree Banerjee. And we did this across a number of different cohort studies where we were looking at this relationship between the DASH diet and kidney function, but also between a similar diet, one that's low in what's called dietary acid load, which is basically diets that are heavy in animal-based proteins, in particular, are going to present more of an acid load to the kidneys to handle and can be problematic. And so we basically, in summary, found that people in these studies who sort of naturally followed a DASH-like diet were less likely to see their kidney function decline, and they were less likely to go on to develop chronic kidney disease. And so because we wanted to then be able to take what we were finding here and actually then translate it over to try to address some of the disparities that we see in kidney disease, we had to think about this important issue, and that is food insecurity. And so food insecurity, which is the inability to afford nutritionally adequate foods in safe way, or to acquire nutritionally adequate foods in safe ways, or basically the inability to afford healthy foods, it affects 13% of households, or more than 40 million people in the U.S., and it really affects the entire United States across every county in the U.S. And we were able to do some work actually showing a linkage between food insecurity and kidney disease. And so we knew that if we were going to develop interventions that would help us to actually get people who may have maybe socially disadvantaged and may have lots of risk factors for developing kidney disease, that we would have to address food insecurity. And so in order to kind of determine how we would go about doing that, we did some qualitative research studies, a focus group study, and this was done with Dr. Amber Johnson during her time as a resident at Johns Hopkins Bayview. And we gathered low-income African Americans who had multiple risk factors for kidney disease, including having a first-degree family member who had kidney disease, kidney failure, actually. And we asked them. We said, well, what are some of the things that you think about when you think about trying to change your diet to follow a more healthful diet? And a few of the things that they shared included that healthy foods are expensive and they're unavailable in certain neighborhoods. One of the quotes from one of the focus groups I'll share with you here They said, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. And so this participant really, I think, highlighted a number of the challenges, including the market forces that are at play here when we think about just availability of healthy foods in low-income communities. They also highlighted that unhealthy foods are more convenient and they're easier to prepare and easier to access, and also that these practices have been a lifelong habit and that they perceive them to be potentially quite hard to break. And so using the information that we gathered from those focus groups and also using the opportunity to build upon a successful pilot study called the 5+ Nuts and Beans study that was led by Dr. Pete Miller, and this was a study of the Johns Hopkins Center for Health Equity, we were able to then successfully obtain funding for a 12-month community-based dietary intervention study, really trying to overcome some of these barriers to access to healthful foods among low-income African Americans who have both hypertension and also have protein in their urine or have albuminuria. And what we're doing in the study is to test whether delivering nutritional advice through a study coach and adopting and coaching them to try to adopt a DASH-like diet, and also providing $30 per week worth of potassium-rich foods that are tailored to the choices that the participants in the study make, and also that are available through a local grocer with which we're partnering. We're basically looking to see if this intervention will lead to a reduction in protein in the urine for these individuals, which we know could actually help reduce the chances that they're going to go on to develop kidney failure. And so we're working with a number of different partners and stakeholders in this work. Some of them represented even here today. And we have an amazing community advisory board that is inclusive of several kidney patients. And they partnered with us through every step of the study to shape the intervention in a way that's responsive to the needs of people who will ultimately, hopefully, benefit from the study. So we've covered a lot of topics here around health equity and kidney health equity more specifically, but I just wanted to highlight for you all the point of why each of us should find that this topic matters to us, and that is because we as an American society are actually all in terms of an investment to individuals who have kidney failure. And so back in 1967, which was a couple of years after after Medicare was adopted, was passed and adopted, there was a committee, the Gottschalk Committee, which put forward a recommendation that the Medicare entitlement actually be extended to all people who had end-stage renal disease. And this would be no matter what their age was. And this, after this report came out, there was also a very dramatic testimony that took place where a dialysis patient actually was wheeled into the floors of Congress and dialyzed in front of Congress for a few minutes. The story that I'm told is that that patient actually developed an arrhythmia at some point, and they had to stop the treatment. But soon thereafter, in 1972, President Nixon signed the Medicare end-stage renal disease program into law, making every individual, no matter their age, eligible to receive Medicare if they develop end-stage renal disease. Now, I show this picture here because I think it's important to recognize that prior to this coverage from Medicare, what was occurring was that there were these what are called God committees that would actually decide who would get this scarce resource of dialysis. And they would use criteria such as, how productive of a citizen is this person? What is their age? Where they had I think the age cutoff was 45 or so. They had a lot of restrictions. What is this person's kind of personality like? Are they someone that's going to attend all their treatments and so forth? And so there's actually a movie that was made about this issue. But since then, we as a country have covered the care of end-stage renal disease patients to the tune of what is $33 billion a year, where we invest this in the care of end-stage renal disease patients. And so keeping that in mind and realizing that health disparities are also extremely costly, the Office of Minority Health has estimated that $50 billion a year are actually spent on health disparities. So basically gaps in care are responsible for $50 billion a year. And the Joint Center for Economic and Political Studies also estimated that about a third of the medical expenses that racial and ethnic minorities incur actually stem from health disparities. And so I think another important point that that makes this issue challenging is that our country actually spends, even relative to other countries, we actually spend much less on social services than other countries. And in fact, we're the only country that spends more on healthcare services than we do on social services. This is from a report from the Commonwealth Fund. And so given kind of this backdrop that these, not only are these disparities, particularly in healthcare, not only are they inhumane, but they're also costly. And so as we think about where we can move from here towards achieving kidney health equity and health equity more broadly, I think that our focus really needs to shift to demonstrating the value of these different efforts and programs that we're pursuing in order to kind of make the case and make the argument that this is work that should be done and work that overall could actually help us financially as a country, as well as help the individuals who are experiencing these health inequities. And so I want to share just a few examples kind of with this backdrop of the types of work that my colleagues and I are trying to do to kind of demonstrate this issue of value. So one is around addressing home environmental risk. So older adults and dialysis patients who are older adults as well often have functional limitations that can basically impair their ability to live independently. And many older dialysis patients will develop a need to actually be placed in a nursing home and lose their independence. So through some work that my colleague, Dr. Sarah Zanton, has led with a program called CAPABLE, which stands for Community Aging in Place, Advancing Better Living for Elders, where she has demonstrated in the general older adult population that a home-based intervention that involves a nurse, an occupational therapist, and a handyman who makes up to $1,300 worth of home repairs to support the participants' functioning can actually lead to reductions in hospitalizations, can certainly lead to improvements in functional status. And I think very importantly for this topic of value, she's been able to demonstrate through her work on working with lots of colleagues across the country that there's been a 7 times return on investment in the subsequent savings from this program, meaning that by investing the $3,000 that it takes to actually provide this full service, that the savings are actually $22,000. And so Sarah and I and other colleagues worked together to actually pilot test a program like this for end-stage renal disease patients that we were able to successfully pilot. And one of my hopes with the President's Frontier Award is to actually then move on to develop a full-scale intervention to hopefully demonstrate that this is an approach that could be beneficial for low-income older adults in particular who are treated with dialysis. The other area that I'm really excited to have been able to kind of work with and support Dr. Tessa Novick in, who's been leading this effort, is around this topic of dialysis patients who are homeless. And as you might imagine, and those who know a bit about dialysis know that being a dialysis patient means that there's a lot of self-management that has to take place, including following a certain way of eating, taking particular medications and being able to store those medications, being able to, for those patients treated with in-center hemodialysis, being able to reliably and regularly attend their treatments 3 times a week and having transportation to do so. And Dr. Novick has been very interested in how homeless patients actually navigate this sort of process. And we were able to with her leadership, we're able to publish this opinion piece recently in JAMA Internal Medicine that really highlights where we think we could move in terms of policy to be able to first capture what the problem is here and understand what the experiences are for homeless patients who are on dialysis, and then ideally to move to a place where we can provide permanent supportive housing for these individuals who are homeless. They're in a number of different other clinical settings. It's been shown that this type of provision actually can lead to reductions in costs. Again, kind of pointing back to this issue or this topic of value. And so I think another area as we think about where we need to go in terms of achieving health equity more broadly and kidney health equity more specifically, I think it's important to think about who that workforce is going to be, who's going to kind of do this work in the future. And this quote by Leila Jana, who it's attributed to her, that talent is equally distributed, but opportunity is not. I think really rings true when we think about who's getting opportunities in the healthcare workforce and in the biomedical research workforce. I was very fortunate to have some of the early exposures that I shared with you all, but not everyone is that fortunate, and I think we're at risk of having a brain drain if we're not tapping into the full spectrum of the talent that is available to us to help solve these very complex problems. And so here at Johns Hopkins, we're very proud of an initiative that we have called the Careers in Science and Medicine, where we have essentially a pipeline initiative focused on high school students, undergraduate students, and then my pride and joy, our post-baccalaureate students, the doctoral diversity program scholars. What we're helping these young, bright individuals do is to gain exposure to research and to really develop a set of accomplishments around research that we know will help propel them into a really successful future. We've now had 3 classes of doctoral diversity program scholars, and I really could not be prouder of them, and I'm confident that these young people will change the world. And I think we really have to invest in people like them if we're going to achieve health equity. And so to summarize here, health equity, again, means that everyone has a fair and just opportunity to be healthier. And I personally believe that we will achieve kidney health equity through engaging multiple stakeholders, including patients, focusing on demonstrating value, and then also providing opportunities for future generations who will be able to carry this work forward. And so I have many people to thank, and they're listed here. Some are here today, including some of my colleagues from the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, the Handle study. Dr. Michelle Evans, who's one of the PIs of the Handle study, is here. And I'm grateful to all the centers that I've had an opportunity to work with, to the National Academy of Medicine, that I've been able to participate in 2 fellowships that they have, which have been very impactful for me. I've certainly appreciated the funding that I've received from NIH, and my colleagues and I have received, my colleagues from the National Kidney Foundation of Maryland and Delaware, some of which are here today as well. And I'm very grateful to the Amos Medical Faculty Development Program, which helped me to get my start in my career. These photos that I'm sharing with you here, one is of our division of nephrology out at a very fun karaoke night, and then the one at the bottom is of our Center for Health Equity at a holiday party. And I have to say, one of the things that has really surprised me, I think in a really good way, is that I think I expected, when I came to Hopkins, I expected us to work very hard. I didn't anticipate how much fun it would be, and I think the reason it's been so much fun is because of people like this. And so I thank all of you, and I look forward to your questions. No questions. I'm going to go, Dr. Rob.
Thank you, Deidra. That was fantastic. In countries where there's more social support, for example, let's say in Canada or in France, what is the burden of kidney disease as sort of heavy towards racial minorities?
Yeah, so did everyone hear that question? So it was a question about in countries where there are, for example, universal health care, do we see a similar burden of kidney disease? So there are certainly disparities exist in many of those countries. I know some of the literature from Canada a bit better, where what's seen is that the First Nations individuals there, they tend to suffer the greater disparities in Canada, and it's thought in part to be because of kind of where they're located in fairly rural portions of Canada. But one of the things I think that's interesting is that in countries where the access to care piece of health disparities has been mitigated by universal health care, you tend to start to see education playing more of a role. So we're in the income issue being taken away, then education, and in many cases tends to drive the health disparities. And some of the work that Priya Vart, Dr. Priya Vart did when he was a postdoctoral fellow here with us at the Welsh Center, looked at that, kind of the difference between rates of, or the disparities that we see in the US compared to disparities that we see in predominantly the UK, and found that the drivers here were more around income, whereas the drivers there were more around education. And Dr. Ray.
Deidra, that was wonderful. Congratulations. As we see a shift toward data science, precision medicine, population health, do you see those systems being trained and ameliorating the disparities, or ensconcing them into structural disparities?
Yeah, you always ask such loaded questions, Dr. Ray. Yeah, many thoughts on that. So as far as precision medicine, so I think there is a place for thinking about social determinants of health around precision medicine as well. So if we think about, the right treatment for the right patient at the right time, and I would say in the right context, I would probably add to that to consider that. And I think we have a lot of work to do to be able to capture and also track as well as consider these social determinants when we're also now having new biomarker data and other things at our fingertips to be able to use. Thinking about kind of the role that the electronic health record could play in that. During my anniversary fellowship with the National Academy of Medicine, had an opportunity to work with a committee that was kind of developing these kind of a list of social determinants of health that should be, we recommended, captured in the electronic health record and then tracked. And so I think that would be one place, if we could move the dial to where more health systems were doing that, I think that would be one place that would be a good start to help us to get to that point. Dr. Philogene.
So one of your quotes talks about access to the healthy food, and how in some areas the access is to the things that are fatty food, or how what part of the research would then focus on merchants, because you can train the people, but then how do we have access to this?
So how do we influence the merchants is what you're asking. Yeah. So. I think that's an important question. So I think in a few ways. I think before we're able to influence the merchants, we may be able to better provide the resources for individuals to make healthier choices, right, and to be able to afford them. So think about a few places. So thinking about the Supplemental Nutrition Assistance Program and how the $30 a week that we talked about, that I talked about in our current study, it really is using the same dollar amount that is provided through SNAP, which used to be the food stamp program. And so I think there's an opportunity for us to provide more guidance to individuals who are receiving that benefit, so that they can, when they are shopping at places, they can make some better choices around what they're purchasing. So I think that's one place. There have been, though, some demonstration projects in some major cities in the country. I think of Philadelphia as being one of them, where they've looked at kind of restocking the shelves of some of these community grocery stores and seeing if the individuals living in those communities would actually purchase those healthier things, and they've shown that they do. And so I think more of that is going to help us to move the dial as well.
Will you guys also deal with the cost of the items? For example, like when they talk about having a farm stand, for example, things would be cheaper there versus if you go to the supermarket, a pineapple is $3, where you can get it at the farm stand for $1.50. So if you're at $30, you might not go as far, and you might not last as long, depending on how many people is in the household. So, I think, figure out a way to decrease the cost of the fresh fruits and vegetables or things that we want them to buy. Could also make a difference.
Yeah, I think you make some terrific points. And one of the things that we're doing in the 5+ nuts and beans for kidneys study is trying to, when we transition our participants in the study over into the phase where they will be shopping on their own and not having the provision of the groceries that we were providing, or that we are providing in the early portion of the study, is we are trying to point them to places like that where they can find these healthier foods on a budget. And it may mean that it's not a full-size supermarket, but it may be a community farmers market where they may be able to receive those. It's Dr. Cooper.
Your very nice presentation. Not surprised. You talked about the value of an intervention like a capable intervention for individuals that have end-stage renal disease, and that being the sort of intervention that you could use to help convince, maybe policymakers to make some changes. What are your thoughts about how you might use some of your research on interventions that take place earlier in the spectrum of kidney disease and demonstrate value to decision makers?
Mm-hmm. Thank you for that. So I'm excited that with our work here in Baltimore, and there's a faculty member at UCSF out in San Francisco, Dr. Hilary Seligman, who's doing some similar work but addressing disparities around diabetes care. And then a colleague who's at UNC in Chapel Hill, Dr. Seth Berkowitz, who's doing some work as well. He was actually mentored by Dr. Seligman. What I'm hoping, and they're all testing, I think we are all testing different ways to incentivize healthy eating. And my hope is that collectively that we may be able to shift policy by showing that across these multiple different diet-sensitive chronic conditions that there are health gains to be made by providing that provision, and I think we could make that case more strongly. Yes.
Can you mention maybe one or two ways that this funding from something like the Frontier Board has really tangibly moved your research forward?
Mm-hmm. Thanks for that. So I would say in a few ways. One, I think it's I know that it has really allowed me to think more creatively about the work, and I'm very grateful to funding sources, some of the federal funding sources that I've received, but I think in some ways in having to follow specific guidelines, I think to basically match up with what those funding sources are looking to fund, it can cause an investigator to think less outside of the box. And I think what I'm most excited about with this is the ability to think outside the box a bit in areas such as I mentioned around, allostatic load and thinking about homelessness and home-based interventions and so forth. I think it's allowed me to feel a bit more creative freedom. So I'm grateful for that.
Great thought. I was wondering, you have a lot of focus on the environment, but are you thinking about adding any kind of genetic component to it? Just like previous, I don't know, with the garden meat or something that can add even more?
So I missed the middle part of what you said. I heard you say that, am I looking to add a genetic component to it? And then to add what piece?
To just talk about any type of, like, maybe just basic DNA, so nothing like intense, like an RNA-seq, like, I don't know, maybe 23andMe or something that you've done in a small way.
So thanks for that question. So I'm quite interested in this gene-environment interaction that we see in kidney disease, and I mentioned that the apolipoprotein L1 gene that has emerged again in the last decade or so to be, based on our understanding, to be an important contributor to kidney disease that we see, particularly among people of African ancestry. And so I've actually, in the Handle study, we've done some work looking at that gene-environment interaction, particularly looking at poverty and then people who had that genetic background, the high-risk APOL1 genetic variant. And I'm very excited to think about how, with our dietary intervention study, that we could look to see if people who have that high-risk genetic variant, we could look to see if the following that more healthful diet actually helped to reduce the risk of kidney disease even among those people. And so, in that way, yes, we are planning to do that. Mm-hmm.
Genetic variant, was that made from like a GWAS that was mostly Caucasian, or did they actually have some African American in it?
Oh, they had lots of people of African ancestry in it. Yeah, it's actually only among people of African ancestry. Yeah. Uh-huh.
If that's okay, I'm going to interrupt very rudely. Let's thank. I'm Denis Witt, Vice Provost for Research. Couple of thoughts. One, how the jury of this prize again and again brought up not only the superb science of Dr. Crews and with an eye on actual impact, but also how she's a team builder. And I think this talk exemplifies this. She has an aura that's truly amazing. You're drawn to her work, you want to be part of it and have an impact. So I think this is an example of that. And more importantly, not really, just as importantly, we have a reception across the hall. Please do come. It's a way to also celebrate her accomplishment, this recognition, and for further conversations, maybe more further team building. So let's thank again Professor Crews for this wonderful talk. Can I get a hug? Yes, you can.